sperm tail, which gives you an idea whether it's live or not. And that is what we normally use. So this is what we use to get out the sperm from the testes, which we think we're going to shoot into the egg.
Thank you.
Ma'am, as we are running out of time, I think Kavita can.
Thank you so much, sir. Thank you so much, Dinder sir, for this enlightening talk. And we had all enjoyed, and the questions were so informative. And just so nice talking to you, sir.
So, thank you very much.
Thank you all.
Thank you very much for inviting me. I will just have to rush out of it. I will not be able to stay at the end.
Thank you, sir.
I have just another program to attend, and I have to lead a panel over there. Thank you so much. Thank you, Dr. Jayakrishan. Thank you, Dr. Pillai. Thank you, Dr. Kavita, Dr. Reggie, and of course, Dr. Kunjumedin, Dr. Kavita.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you very much.
Thank you.
Bye-bye.
So without wasting much time, we will go to the next session. That is, we'll be having a talk on what is new in male infertility by Dr. Jayakrishan, sir. And we have two chairpersons for introducing Jayakrishan, sir. We have none other than Dr. Laditambika, madam from Alleppey. She needs no introduction to our crowd. She is professor and head of the Department of Gynecology, Mandana Medical College, Alleppey. She's an excellent sonologist with very much interested in infertility treatment and laparoscopy. I invite you to this meeting, Laditambika, madam. And our second chairperson is Dr. Kavita Vasudevan, who is president of Kollam Society. She's a senior consultant from Upasana Hospital and Ashtamadi Hospital. She was a health service consultant, retired, and she is also very much interested in infertility work and laparoscopy. I invite you, Kavita madam and Laditambika madam, over to you to introduce the speaker and to start the session.
Thank you, Dr. Reggie. Am I audible?
Yes, madam.
Thank you for inviting me to this program and to listen to all these excellent talks. Again, Dr. Jayakrishan is very well known to all of you, and he needs no introduction. He is the Director and Chief Consultant in Reproductive Medicine, KJK Hospital, Trivandrum. He has more than 35 years of experience in treating subfertile subjects. He has performed more than 14,500 endoscopic procedures during last 23 years. Principal investigator for 3 research projects under STEC, 36 publications in national journals, winner RKK Tamban Award 1983, Foxy Korean Award in 1996. He has trained more than 262 trainees in laparoscopy and hysteroscopy during last 22 years, and very much involved in 2 international trades, PALO study and MSD study. He has contributed chapters in several textbooks. Over to you, Jayakrishan, sir.
So thank you. Okay.
I request all the others to mute the mic.
So thank you, Dr. Laditambika. And I'd like to thank Dr. Reggie for the kind invitation, and my congratulations to Dr. Kunjumedin for the bringing out the first session of the reproductive medicine of the KFOG. And the topic which has been given to me is male infertility. So we heard Dr. Sunil Jandal talking on the embryology part of the newer perspectives, but I'd like to take you through the clinical perspectives in male infertility. So we all know that infertility affects 10 to 15% of men in the prime reproductive age, and male factor infertility not fully understood, and approximately half of it is unexplained or idiopathic. And 15% of cases of the conventional semen analysis do not reveal obvious anomalies. And the spermatozoa of infertile men have lower DNA integrity than fertile men. This is important.
So
slides,
slides, you can start the slideshow, sir. It's still in the computer mode. Yes, sir. Yes, sir. Thank you, sir.
Yeah.
Yes, sir. Thank you.
So the most important point I would like to stress is 15% of the cases of conventional semen analysis do not reveal obvious anomalies. And one more regarding the spermatozoa infertile men that have lower DNA integrity than fertile men. And this is important because the genetic information is passed on to the next generation. So the agenda I have in the next 20 minutes or would be to go through the recent changes in the WHO lab methods. And the second agenda would be increasing evidence of sperm DNA fragmentation on reproductive outcomes, the detrimental effect. Then I'm going to summarize the findings of the varicocele related infertility and outcomes of microsurgical varicocele repair, and critically discuss the current management of men with non-obstructive azoospermia seeking fertility. So I think more of the embryology part has been covered by Sunil Jandal, so I just stick on to my clinical aspects. So semen analysis is the most widely used biomarker to assess male infertility. When a couple comes to the clinic, the best way is to diagnose whether the male is normal or not to look at the semen analysis. But in 2010, the WHO introduced important changes to the methods for conducting and reporting results of the routine semen analysis. The one was it is calculating volume by weight rather than the graduated pipette. The second point was the motility was expressed in two categories, especially progressive and non-progressive, in contrast to the 4 categories in previous WHO manuals. And third, the morphology by strict criteria was a Tigerberg criteria as opposed to the WHO criteria in the previous manuals. When you look at the reference values from 80 to 2010, the volume has almost remained the same. It has come back to 1.5. The count initially started with 200, then it has come back from 20 million to 15 million. And the motility, the initially 1980s, it was more than 60%, has come to 40%. And the progressive motility has increased from 25% to 32%. Vitality has almost remained 58 from 50 to 75. The most important thing has been the morphology, which was 80% supposed to be normal, has come back to more than 4%, or 4% at least normal morphology. And the leukocyte count almost has remained the same. So when you critically look at the WHO laboratory manual, this analysis was based on the 5th percentile of 2000 men who were recent fathers. And looking at the 5th percentile, you see that volume was 1.5, the count has come to 15 million, total count has come to 39 million, motility 40%, progressive motility 32%, normal forms you need only 4% and 58%. So the 5th percentile was taken. It would have been better if you took the 50th percentile, but you see there's a wide variation in the motility, the total count, and everything. So this is where the criticism starts regarding the 2010. So the drawbacks of the WHO 2010 semen analysis is that it is based on a population-based study of recent fathers with time to pregnancy of 1 year or less. And the data obtained from 1,900 men was obtained to generate percentile distributions of semen volume, count, motility, vitality, and morphology. And as I told earlier, the 5th percentile was established as a lower cutoff limit for normalcy, making the reference values much lower. So it has been suggested that caution should be exercised to interpret a semen analysis in view of the new changes which has come from right back from 2010. So WHO laboratory methods for evaluation of humans semen, the clinician should not expect an analysis of widely ranging parameters on the whole ejaculate to give robust discriminatory information of the male fertility potential. you have to look at with a pinch of salt, or look at once again if you find there's a wide variation on the report on this basis alone. So the most important thing I would like to stress is the male infertility evaluation should go beyond a simple semen analysis. Apart from history taking, physical examination, which is quite important, endocrine profile of the patient, the laboratory semen function test also should be included as a minimum standards when you evaluate. So you should go beyond just a simple semen analysis, because there are a lot of things you have to take into consideration. The conventional semen analysis is not enough because it is not taking into account of the single strand break in the chromosomes, the damaged and the double strand break, the intra-strand break and inter. All these things are not taken into consideration in a semen analysis. So what you can do to find out whether there is a break in the in the chromosomes, you have to look into the DNA fragmentation. We all know that the oxidative stress affects the sperm during the transit through the epididymis and after ejaculation. It is a major cause of the sperm DNA fragmentation outside the testis. There are various etiological factors which could be implicated for the impairment of the DNA integrity. That includes cigarette smoking, radiation, chemotherapy, when there are a lot of pus cells, varicocele, cancer, obesity, and advanced paternal age. More than 45 years, you find the DNA fragmentation starts increasing. So what happens if you have a high sperm DNA fragmentation? Reduced fertility rates have been reported in cases of high sperm DNA fragmentation, which could lead to impaired embryo development, compromised integrity of the embryonic genome, and increased rates of miscarriage. So even recurrent pregnancy loss has been attributed to the high sperm DNA fragmentation. What can be the clinical utility you can make? Suppose a patient comes to you with a increased sperm DNA fragmentation. Instead of asking the patient to have an ejaculate of 3 to 4 days or 5 days, you can ask them to abstain for 1 or 2 days before the semen collection, especially when procedures, the semen is being taken for IUI, IVF or ICSI. Longer abstinence periods increases the sperm DNA fragmentation, and if you have a shorter abstinence period, you find that it is much better when you correlate it with the sperm DNA fragmentation. So ASRM has recently conceded that determining the values of sperm DNA fragmentation may be clinically informative for counseling the patients who are coming for IUI as well as IVF or ICSI procedures. A shorter abstinence period is always better with a higher sperm DNA fragmentation rate. What's the difference between a testicular sperm and an ejaculated sperm? It has been found that the sperm DNA fragmentation was 5-fold lower in a testicular sperm when compared to an ejaculated sperm. That is why in cases of severe oligospermia, asthenospermia, more and more use of the testicular sperm or ICSI it's been associated with better outcomes. So whenever you find that the count and motility are very low, the sperm DNA fragmentation is high, and if you go for a testicular aspiration, you find that your outcome could be much better. So as I told earlier, there are various factors associated with sperm DNA fragmentations. Apart from radiation and temperature, of course, fever is one of the things which increases the sperm DNA fragmentation. The lifestyle things has to be kept in mind. Obesity, smoking, and aging is also a factor in regard to the DNA damage which is happening. Men with unexplained infertility also has elevated sperm DNA DNA fragmentation, and IUI outcomes are negatively affected by elevated. So the men having elevated sperm DNA fragmentation, you find the IUI outcomes are much less when compared to the group which didn't have an elevated SDF. So Oral antioxidants decrease the sperm DNA fragmentations and improve aortic outcomes, and they are recommended in all patients prior to ART procedures. Definitely, oral antioxidants decreases the DNA fragmentation. So it is imperative that you put them on oral antioxidants. And which are the oral antioxidants you can give to infertile male? The drug or the tablet should contain vitamin C, vitamin E, folic acid, zinc, and selenium. The old concept was to give for 90 days, but nowadays the duration is minimal of 2 months, at least 2 months of antioxidants, mainly which contains all these antioxidants will help to reduce the sperm DNA fragmentation at least for 60 days. Now I am going to take you through the management of azoospermia, which Dr. Sunil Jindal has beautifully explained the laboratory aspects, but I'll go through the clinical aspects, the management of azoospermia. And azoospermia is a complete lack of sperms in the ejaculate. Always make it a point to centrifuge the ejaculate, and you find that even in the centrifugation, after centrifugation, you're not getting sperms. It is a total azoospermia seen in 1 to 3% of the male population and 10 to 15% of the infertile males. And this slide already has been explained by Dr. Sunil. You divide into obstructive and non-obstructive. And non-obstructive, you have the spermatogenic failure, hypo, how to diagnose them, and how to diagnose spermatogenic failure, and hypo, you will have very low levels of FSH and LH. And non-obstructive azoospermia due to spermatogenic failure is an irreversible condition. It happens due to congenital causes like dysgenesis or cryptorchidism or genital abnormalities associated with Klinefelters. And an acquired non-obstructive azoospermia can come with a testicular torsion, trauma, post-inflammatory, especially mumps orchitis, and exogenous factors, of course, the cytotoxic drugs, irradiation, systemic diseases like liver cirrhosis, renal failure also can cause non-obstructive azoospermia, and some of the cases are of unknown etiology. So what's the medical algorithm, especially by Sandro Esteves and group? They look at the testosterone and estradiol levels. And whenever you find the testosterone is less than 300 nanogram per deciliter, and when the testosterone estradiol ratio is less than 10, either you can get a patient's less than 10 ratio, or you can have the testosterone and estradiol ratio more than 10. So if it is less than 10, that means aromatase hyperactivity is there. And aim is to boost testosterone production by giving aromatase inhibitors. And they recommend anastrozole 1 milligram orally 4 times a day. Suppose you have the testosterone estradiol ratio more than 10, there is a pure hypogonadism. There you start off with HCG, 250 milligram weekly once. And as told earlier, after a period of 6 weeks, add recombinant FSH or urinary FSH preparation twice weekly, especially if the FSH levels are less than 1.5 milli-international units. So the medication is aimed especially with the principle of high intratesticular testosterone levels are essential for regulating the spermatogenesis in combination with Sertoli cell stimulation by FSH. And paradoxically, weak stimulation of the Leydig and Sertoli cells by endogenous gonadotropins due to the high baseline FSH and LH levels results in a very low amplitude for it to stimulate. So you have to start stimulation with HCG and add FSH after 6 weeks and continue the process at least for 3 months to see whether there is any change in the spermatogenesis. And it has been found that medical therapy may increase the sperm retrieval. Suppose you have a group of patients coming for sperm retrieval, medical therapy may increase the sperm retrieval success in men with spermatogenic failure. So those patients who received HCG on the left side, you find that more than 15% of the patients with previous failed sperm retrieval, when they were given HCG, post HCG, the retrieval was much better. And microdissection TC also helps you to retrieve sperms much better. So sperm retrieval is a method of choice, and Dr. Sunil has beautifully shown his video of the various procedures in sperm retrieval, but you have to counsel the patient. TISA gives you a success of 15 to 50%. Testicular sperm extraction, TC, gives you much higher, 20 to 60%, whereas a microdissection of the testicular sperm using a microscope or the micro TC gives you a success of 40 to 67% of success in spermatogenic failure after sperm retrieval. So this slide, I think you have to discuss and counsel the patient. The patient should not think that just with the sperm retrieval, you're going to get 100% sperms in all cases. So it has been shown that micro TC is more effective than conventional TC. And overall, it shows that the sperm retrieval success is higher with micro TC. And these are the various things, various histology categories. You get hypospermatogenesis, and the sperm retrieval is around 93% and 64 with the conventional. If it is maturation arrest, you get 64% and 9%. And fertility is histologically much lower sperm retrieval you get in fertility only syndrome. So micro TC is more efficient than conventional TC. In micro TC, you take about 9 milligrams of testicular tissue, whereas in conventional TC, you may have to take about 65. So definitely you're preserving a lot of the testicular tissue when you go for micro TC. So the tissue removed is much less in micro TC when compared to the conventional TC. And more important is the laboratory handling of the epididymal and testicular spermatozoa. And what can be done to improve the sperm injections outcome is to optimize the sperm retrieval, go for the mechanical mincing, enzymatic tissue digestion, and avoid iatrogenic damage. And definitely a clean room IVF with positive pressure IVF is better in severe male factor infertility. A conventional IVF lab without AHUs, you find that the results are much lesser when compared to the clean room IVF. And the top quality embryos also you get in a clean room when compared to the conventional. So definitely clean room IVF lab positively has got an impact on the cycle outcome and severe male factor infertility. Now I will take you through the prognostic factors for sperm retrieval. As I told you, 10% of non-obstructive azoospermia harbor microdeletions. Is it with long arm of the Y chromosome? So the application of the molecular technology recognizes 3 regions in the Y chromosome. They have been identified as AZ of A, AZ of B, and AZ of C, each one a major candidate. And what happens is the deletions affecting the AZ of subregions causes a disruption of the sperm cell development. So I'll just take you through the sperm retrieval is not recommended to men with complete deletions involving AZ of A and AZ of B. And with AZ of C, Y chromosome microdeletions, sperm retrieval is offered. But those deletions invariably transmit from father to the son, and counseling has to be done. So favorable is AZ of C, Y chromosome microdeletion, whereas your Y chromosome microdeletion, if you are done before the sperm retrieval, you are getting the report of AZ of A and B. It is better to avoid the sperm retrieval in this group of patients, whereas in AZ of C, you get 50 to 70% of sperm retrieved. So micro TC advantage would be the lower tissue extraction lessens the testicular damage. And in a study involving 356 patients with non-obstructive azoospermia, The sperm retrieval success, according to the histopathology characteristics of it was with hypospermatogenesis, it was 100%, maturation arrest 40, and certainly cell alone syndrome, it was less than 20%. So intratesticular testosterone levels increased after HCG, stimulating the residual spermatogenic areas. And after HCG, you find the intratesticular testosterone level increase, and the sperm DNA synthesis also increase, so that you get a positive results in more than 15% of the case after exposure to HCG. Coming to the last part of my talk regarding varicocele repair. Varicocele approximately affects 5% of men, approximately seen in 5% of men in non-obstructive azoospermia. It is debatable whether varicocele is coincidental or contributory to spermatogenesis disruption, but surgical repair of the clinical varicoceles has been carried out in an attempt to improve the sperm production. And after varicocele correction with non-obstructive azoospermia, about 44% of the treated men had enough sperm in the ejaculate, and to avoid sperm retrieval also, by this group of Esteves, Agarwal, and published in the Asian Journal of Andrology. So just repairing of the varicocele with azoospermia, 44% is a very good figure, and you can get the sperms in the ejaculate. Coming towards a glance towards a future, ICSI with immature germ cells has yield conflicting results. Despite some deliveries have been reported with healthy offspring, the method has extremely low efficiency as currently used. So using the spermatids or spermatogonia is not recommended. Only in a research setting you can try. And concerns have been related to the potential transmission of genomically imprinted disorders, raising the doubt regarding the safety of these procedures. So this is regarding the glance towards future. It is always preferable to get a sperm rather than a spermatogonia or an immature spermatid. And you find these are the concerns regarding the genomically imprinted disorders and low efficiency as currently used. To conclude, the newer perspectives as a clinician, I would say that conventional semen analysis is limited as a surrogate for fertility assessment. Along with that, if you can do a sperm DNA fragmentation, the ideal test to do will be a sperm SCA or SCSA is better tool for clinical decision making. Definitely all patients should be put on antioxidant therapy, especially those after microsurgical varicocele repair. And TSAT-ICSI can improve the ART outcome, and varicocele repair also improves the ART outcome in selected individuals. The third conclusion would be the best management of azoospermia-related infertility includes proper diagnosis, look at the testosterone, look at the FSH, look at the estradiol, find out the ratio, and then take a decision whether to start them on HCG for 6 to 8 weeks and adding on FSH, and optimize the sperm production and optimize the microsurgical retrieval and the state-of-art laboratory care, and tailored control over and stimulation also helps you. So empowering clinical decisions and treatment efficacy, the conventional semen analysis, empirical treatments, and the conventional surgeries should be replaced by sperm analysis plus DNA fragmentation testing, microsurgical methods of varicocele surgery, as well as retrieval techniques, azoospermia, Y chromosome molecular diagnosis, Y chromosome what you call the molecular diagnosis to find out which zones are affected. Go for sperm retrieval in AZFC indications, genetic diagnosis, and you target the therapy so that you can get a better outcome in this group of patients. So thank you very much, Dr. Kunjumoideen and Dr. Reggie, for the kind invitation. And I'm ready for the questions.
Thank you, sir. Lalitambika madam and Kavita madam can take over for the discussion.
So there are many questions in the chat box. You can go to the questions in the chat box.
Yeah, I'll come to the chat box. How is DNA fragmentation done? Which test has the best result, and how is the cost? DNA fragmentation is done by many tests. The test of which we do is the SCSA, where the sperm has to be 1 or 2 days abstinence is put in the liquid nitrogen container and sent to the lab, which does it. And the SCA test also is good enough. The average test costs about 6,000 to 7,000 rupees, and I think you can have your what you call your lab also do it once you have larger numbers. Uh, from Reggie Rome of Clomid in subfertile men. We give clomiphene in subfertile men, especially when it is associated with oligospermia. 25 milligram is quite sufficient. We seldom go for 50 milligram. 25 milligram at bedtime for 6 to 8 weeks or 12 weeks is a good choice. For oligospermia, for asthenospermia, the other group of drugs especially has to be given. Long-term use of antioxidants, I don't think that there is any problem with long-term use of antioxidants. People take antioxidants in the COVID era also to reduce the uh, problems associated with it. They raise your immune response, and so there is no problem. You can have it one daily. And the duration of the HCG, as I told you, we give 250 microgram of 0.25 milligram of recombinant HCG, or we give 2000 units of HCG twice weekly. And after 6 weeks or 8 weeks, we look at the testosterone level, see whether it has come normal, then continue the the add-on FSH along with HCG. The FSH is given twice weekly, and HCG is given weekly, and you may have to give it for a minimum of 3 to 6 months. So the testosterone levels helps you to find out whether the intratesticular testosterone has come back to normal. And one more question from Dr. Reggie regarding varicocele surgery, the ideal candidates. I think non-obstructive azoospermia, definitely you find that a good results, you go for a microsurgical correction of the varicocele, getting a success of 30 to 40%. Or sometimes you find, at least if they go for mild or moderate, mild oligospermia, definitely you find you can use ejaculate sometimes instead of going for the sperm retrieval. We usually give HCG to this group of patients, 2000 twice weekly for 6 weeks to 12 weeks. And you find the post-operative HCG is much better in this group of patients. We do recommend the microsurgical, and the dedicated urologist or the andrologist should do this surgery, and you have a better outcome following that. Reggie, these are the questions I see on my screen. Anything more? I don't.
No, I have a question.
Hmm.
In a case of OAT, with varicocele, you have done varicocele surgery. So do you wait for another 3 months before going for ART?
So definitely, this group of patients, we give HCG, as I told, 2000 twice weekly, or recombinant maybe 250 microgram weekly once for 6 weeks or 12 weeks. We have to wait before you take this group of patients for, because immediately azoospermia, non-obstructive azoospermia, it takes some time, minimum of 8 to 10 weeks for the sperm to appear. So definitely.
No, I was talking about OAT, oligoacino with varicocele. Do you wait for 3 months before going for ART if she has not conceived?
Yeah, if you look at the FSH levels, and the FSH levels are not elevated, and OATS patients, oligoacinospermia with varicocele, you can think about whether your varicocele is going to do any good. You have to wait for about 6 to 8 weeks. But definitely nowadays, whenever you find that you can use the Pixie dish also to select the sperm, you need not wait in this group of patients. But on an average, if you're aiming for a varicocele surgery, then yes. Otherwise, you can take this group of patients for Pixie, and you can go ahead with the procedure.
Lalitambika madam, Kavita madam, anything more?
Thank you, Dr. Jayakrishnan, for an excellent talk.